Much. We shall now go on to our next speaker, Dr. Amrutha Sindhu. She's a medical consultant, pediatric ophthalmology and adult strabismus from Arvind Eye Care System at Coimbatore. And she's going to be talking on transposition procedures in strabismus. On to you, doctor.
Thank you, ma'am. I hope my slides are visible.
Yes, yes.
Okay, at this outset, I would like to thank Aios for this beautiful opportunity. So in next few minutes, I would like to talk about transposition procedures. So the aim of where do we do this transposition procedures? Basically in paralytic strabismus, monocular elevation deficits, Duane retraction syndrome, any lost, absent, or slipped muscle. So one important point in this transposition procedure is that we should always do a force reduction test, and it should be free. So if not, we have to always resist the antagonist. So the aim of this transposition procedure is to align the eyes in primary position, to improve the paretic gaze, and also to improve the diplopia-free visual field for the patient. So basically, I would like to classify these transposition procedures based on the nerve palsy which is involved. So the most commonly done procedures is for the 6 nerve palsy. So 6 nerve palsy, the commonly done procedures are full tendon vertical rectus transpositions, Hummelsheim procedure. Jensen's was previously done, but not much in practice these days, and the Nishida's technique. So the VRT can be broadly classified into, it can be a double muscle VRT or a single muscle VRT. So double muscle is either a full tendon VRT or a partial tendon VRT. Single muscle is preferred if you have to correct a small degree of hypo or hypertropia and for smaller deviations. So both this double muscle or a single muscle VRTs can be added with MR recession if there is a MR tightness, or it can be added on with the augmentation sutures to increase the amount of the correction is required. And also some surgeons prefer to use Botox in the antagonistic muscle in order to reduce the tightness of the antagonist. Either this Botox is given along with the transposition, or following the procedure also, injection is given. So coming to the vertical rectus transposition as such, the full tendon vertical transposition, although we can do it, but usually most of these palsies are associated with the tightness of MR. So including the MR along with 2 full tendon VRT is, there is a high risk of getting an ASI. So usually the partial tendon VRT is what is preferred because it spares the ciliary vessels and hence can be combined with MR recession. So we can do a single muscle VRT, as I already told. It can be an SRT or an IRT, which if we added with augmentation and combined with recession gives similar results. So VRTs can usually correct up to 25 to 30 prisms of esotropia, and when added with the MR recession can correct up to 50 to 60 prisms of esotropias. One of the most common procedure done for 6 nerve palsy is the Hummelsheim procedure. Although the original Hummelsheim has got a lot of modifications over time, this Hummelsheim is nothing but a partial tendon VRT. So usually this the partial tendon of superior and inferior rectus is transposed towards the paralyzed LR. So this can be, this augmented Hummelsheim is nothing but the partial tendon which has to be transposed is resected, and it is split, and then the split lateral rectal ends and fixed at the lateral rectus. So this can also be combined with augmentation, and also this the advantage of Hummelsheim is that it can correct large angle of esotrophias up to 40 prism diopters, and also the one more advantage is that it improves the abduction. So a small note on augmentation sutures as such, the augmentation improves the abducting force by creating an additional force at the point of sutures. It is seen that using this augmentation sutures can improve the abduction of about more than 50%. The commonly used augmentation suture are Foster sutures. Foster suture is nothing but the vertical muscle bellies are fixated to the sclera about 8 mm from the LR insertion, that is almost near the equator. So the other less commonly used is the right suture, which is nothing but the intermuscular augmentation of 8 mm posterior to the insertion. Although this is not very commonly done because there can be a splaying of muscles over time, and the sutures may not be fixed at a desired point. So the complications of VRT is it can cause adduction limitation, although patients may not complain about it. It is seen about 13 to 43%. Vertical deviations and torsional diplopia are quite common. So conventional VRT can cause small angles of vertical deviation. It is seen 0 to 40%, and augmentation can cause it 0 to 30%. And as we all know, it can cause, especially full tendon, can cause there is a more risk of anterior segment ischemia. Coming to the modified Nishida's technique, which is the most favorite of many of the surgeons, because it is a no split, no tenotomy transposition procedures. Here, 1/3 of the vertical muscle bellies are sutured into the sclera in supero and inferotemporal quadrants, about 8 to 10 millimeter posterior to the insertion. So Nishida is almost used in all kinds of surgery, not only in the 6th nerve palsy, also in monocular elevation deficits, transected medial rectus, inferior rectus aplasia. So the advantage of Nishida, modified Nishida, is it corrects a large angle of deviation, as there is no splitting or no tenotomy involved. There is almost no risk of anterior segment ischemia in these cases.
You have 1 minute remaining, ma'am.
It has good results with the resurgeries and complex surgeries. So a short video. I would like to thank my mentor, Dr. Sandra ma'am, for this beautiful video of modified Nishidas. Here, initially, medial rectus has been recessed because FTT was positive. So MR has been recessed by about 6 mm. Then through a fornix-based incision, superior rectus muscle about 9 mm posterior, there is a suture taken in 1/3 of muscle belly, and it is fixated to the sclera in the superiotemporal quadrant using a non-absorbable suture. Similarly, through the fornix-based incision in the infratemporal quadrant, IR is sutured at 1/3 tendon is taken, and it is fixated in the inferotemporal quadrant. So this gives a very excellent result, especially gives a very good result in the primary gaze, and can correct large angle of deviation. In short, about the 3rd nerve palsies, although it is very difficult to correct 3rd nerve palsy, recently many of the surgeons started doing medial transposition of split lateral rectus, either pre-equatorially or just behind the insertion of medial rectus, which is known to give good results. In short, about monocular elevation deficits, we all know there are various causes for MED. It can be paralysis of elevators, inferior rectus restrictions, or it can be a supranuclear pathologies. So surgical planning basically depends on the etiology, so which is most commonly diagnosed on table after force duction test. So Knapps procedure is the commonly done procedure for MEDs. So the results of Knapps are variable. There are again various modifications of Knapps. The conventional Knapps can correct up to 30 to 35 prisms. Augmented Knapps can correct up to 40 prisms. Sometimes we also do a partial tendon Knapps to correct the horizontal deviations associated with MED. So last but not the least, the loop myopexy, which is used for high myopic strabismus fixes, which is nothing but union of SR and LR bellies in the superiotemporal quadrant, 15 millimeter posterior to the limbus, with or without scleral fixation. A short video of loop myopexy. Again, I would like to thank my mentor, Dr. Sandra, for this beautiful video. It's a large esotropia. Due to high myopia, left eye was actually strabismic amblyopia. The surgery is done. Here, MR was found to be tight. It is recessed. I would like to just fast forward it for the want of time. Again, here we can see the LR is shifted down. It is hooked. It is split. And about 9 to 10 mm posteriorly sutures are taken. And both the muscle bellies are I'm sorry about that. Yeah. Both using a non-absorbable suture, the muzzle bellies are joined together so that the herniated part of the globe is pushed back and the normal anatomy of the muscles are retained. So this is in short about the transposition procedures.
Thank you very much. Again, amazing talk. And I have just one question before Veena can take on. How would you manage sixth nerve palsy with very large esotropia and nil lateral rectus function? Anybody on the expert panel or would like to answer?
Yes, ma'am. We have to do the FPT first, see for MR contracture. So most of the time it has a very tight MR because long-standing esotropias, long-standing LR palsy can have a contracted MR. So we should always combine with the MR recession. So either we can go for a Hummelsheim or a modified Nishida's technique to correct large angle sixth nerve palsies, esotropias.
Dr. Rohit, would you want to add anything?
No, I think she's covered it very well. We had published a meta-analysis of the various transposition procedures in IGO, where we found that SRT with an augmentation suture with an MR recession is actually very, very effective. It's as effective as a partial VRT with augmentation with an MR recession. So I personally prefer an SRT with posterior fixation with an MR, adjustable MR recession. And I would say it would cover almost very, very large, up to very large angles of esotropia. So you could have a large MR recession adjustable with a superior rectus transposition with a posterior Foster's suture. I prefer. I don't prefer a right suture because, as Dr. Sindhu mentioned, there is long-term splay of the muscle and the effectivity of the transposition gets reduced.
And would you also combine it with a Botox injection to the medial rectus?
So I do not combine it in the first go with Botox. Like I said, usually a large MR recession with SRT with posterior fixation is very, very effective. But if there is a residual early on, you could think of a large residual early on, you could add a Botox so that as the transpositions we have realized get better with time as the tissue adapts. So if you have a small undercorrection, it will get corrected over time. In fact, I dread a perfect correction because I know it may get an overcorrection over time. So small undercorrection, leave it. A large undercorrection, Botox in the medial rectus.